this is just a sample of some of the diagnostic profiles in the DSM. Anybody familiar with the DSM, Diagnostic Statistical Manual of Mental Disorders? So you've probably seen some of these, or at least heard of them. Autism spectrum, borderline, bipolar, anxiety disorders, depression, mood disorders, schizophrenia, schizoaffective disorder, and that's just a grab sample of diagnostic profiles that are in the DSM. Anybody that's seen the DSM knows it's about this thick. It's had about 10 edits, and it's a beast to get through. So you know that that is barely scratching the surface. So how do you treat all those? So the first problem that you face is most people have been in and out of the hospital system. They've not really been diagnosed. Maybe they spend 2 days in the hospital, maybe they spend 5, heck, maybe they spend 2 weeks. I've seen people spend more, but largely it's a short-term stay. They get very little time with a psychiatrist who's spending 20 minutes giving them an evaluated profile. They're bipolar, let's give them Haldol, let's give them, Thorazine, calm them down, send them out the door or on the street. Yay, problem solved. And not only do we have a very limited diagnostic profile on this person, we also have a very limited treatment profile. So medication management. So the next slide here is just a grab sample. This is 3 pages of different treatment modalities that you can use for treating various conditions. Medication management is the single most highly used treatment modality that we in the United States offer to people who suffer from severe and persistent mental illness, because we don't know where they're going. Are they going to get care afterwards? I don't know. Do they got any money? I don't even know if there's a residential program that'll take them. I don't know if they've got enough money or insurance to afford it or whatever, so I'm going to dump them with a bunch of meds. I'm going to hit on the street and wish them the best of luck. Maybe they'll get with services that are local to your community. Maybe they've got an ACT team. Maybe they'll go to the IOP. None of which is really appropriate for care for a person who's just come out of the hospital for a psychiatric condition. So no wonder they end up cycling through the revolving door all the time. So, medication assisted treatment, depending on where you go, if a person's got substance use issues, you've got substance use treatment providers that don't believe in MAT, and you've got others that are strong components of it, and there's a narrow band down the middle. So you get a lot of disagreement in that field. Cognitive behavioral therapy, it's the kind of the gold standard for treating people with autism. DBT, probably heard of. Exposure therapy. Anybody know what exposure therapy is for? What's exposure therapy for? PTSD, OCD.
Phobias?
I'm sorry?
Phobias?
Yes, absolutely. So, ECT, Nurse Ratched, right? They don't do it that way anymore, thank goodness, but that's the image we all get, right? Group therapy, family systems therapy, EMDR. Anybody done any EMDR? Yeah, so EMDR is pretty commonly used for a wide range of people, but it's really good for PTSD and trauma and that sort of thing. Art therapy, equine therapy. There's all kinds of modalities that are out there. So the trick is, and the problem that we end up having to solve, is matching the condition with the treatment. So that's problem one. First, we've got to get the right diagnosis. What are we treating? Second, we figure out how we treat it. What's the right treatment modality we're going to use? Third, we got to pick the level of care. So there are levels of care, and each one of these levels of care have a different lengths of stay. And the lengths of stay are on a spectrum, right? So hospital is your highest level of care. They can lock you in. Down below that, you've got crisis centers, stabilization centers, and diagnostic centers, often kind of coupled. Diagnostic and stabilization. You'll see those, and they might be attached to a hospital, or they have a relationship with a hospital, so if a person gets acute enough, they can just send them over there, calm down for a minute, and come back and start figuring out what's going on. But even that, that kind of evaluative program is going to last at least 2 weeks, sometimes a month, sometimes 6, because especially for a person who suffers from thought disorder or schizophrenia, if you just had a psychotic episode and you start assessing the person immediately after the psychotic episode, what happens? The psychotic features scream so loud, you don't actually get anything about what's going on underneath. You don't understand whether it's trauma, is it a mood disorder? And if they go over the top of the mood disorder, they're having psychotic features, or they really just truly have psychosis and they need to be an honest antipsychotic all the time. Like, you don't know, because you're too busy hearing the loudness of the psychotic episodes. So you gotta let them cool off a little bit before you start assessing. After these hospital/clinic kind of care, residential care. And most providers, even good programs, don't really know more than what's in their area. So they may, and if you don't live in an area like Kansas City, for example, there is not really, if you want residential, high quality residential treatment in Kansas City, you're gonna have to drive to Ohio. So, now that doesn't mean you can't go to the hospital. You might find an IOP or an outpatient center or something like that, but if you've got a pretty severe and persistent condition that needs a lot of care and needs a lot of diagnostic work, it's not here. You're gonna have to go out of state. Most people don't know where those resources are. One of the things that we do as therapeutic consultants is we travel. Our team visited 250 programs across the nation last year. You've got to travel. You've got to go kick the tires and meet people and see programs and learn whether or not they can do what they say they're gonna do. What is their cost profile? Is it in a slide? Are they in network with insurance? There's all these questions we have, and we try to get those questions answered by visiting programs and developing relationships and saying, hey, what kind of person is the person that you serve? What kind of treatment do you provide? Residential treatment, length of stay, anybody know? What would you guess? Most people will think 30 days. I would tell you somebody with a severe and persistent mental health condition needs at least 60 to 90. So you look at a spectrum, 30 to 90 days worth of care. We say 30 days, why do we say 30 days? Because that's what insurance will pay for. They put those what I would call false treatment periods into play back in the 90s when I started in the field. I've been in the field since 1994. In 1995, managed care came in and said, you know what, we're chopping these off and we're dictating treatment periods. 30 days was it. So, at any rate, you get residential treatment, 30 to 90 days, and then most people, one of the most vulnerable steps you'll ever take. So, anytime you're coming from a highly structured clinical environment, everybody's caring for you, they're talking to you, they're helping you calm down, they're helping you process your problems and everything else. Then you're gonna step down, you're gonna go home. And then there's no clinicians and there's no support and there's no anything else. It's probably one of the most vulnerable steps a person takes. If they don't do something to transition from a residential environment to a supported living environment of some kind that's capable of managing someone with mental health conditions and bed management issues and all the other things that come along with that. They have anxiety, they don't sleep well at night, they need med adjustments, all those pieces. It's complicated stuff. You need people who know how to do it, and you need to stay on top of it. Because when you don't stay on top of it, what happens? You go back to the hospital. So 30 to 90 days residential, step down care, you've got 2 levels of care that kind of follow from there, PHP and IOP. Do we know what those are? Partial hospitalization. Some come with residential placement, some are just standalone, they belong to a community. A lot of these folks that are coming from this kind of hospital experience, they need a supported living environment while they do PHP and IOP. If you're a person with a severe substance use issue, the chances are good this process looks like 2 years. And at the end of PHP and IOP, 6 to 9 months, we're just sober living. Standard, supported, sober living. You're going to meetings, you've got coaches, you've got people that are helping you manage that. What's the date on which most people who suffer from a substance use issue relapse more than any other? Their year anniversary.
Oh, wow.
Next would be the day after they leave. And it depends on when, did they just leave 28 days worth of care? Yeah, that's probably true. But for people who have managed to be sober while they were in treatment and follow through the plan, their year sobriety date is one of the most flagrant relapse periods for most people with a substance use issue. So you gotta get 13 months. 1 year gets you 2, 2 years gets you 5. That's what they say. That's the math. So, levels of care, lengths of stay, and if the people, especially the people that, you folks are seeing, that have these kinds of conditions, they don't play small. There's the worried well, right? And then you've got people who start to suffer from mental health conditions, maybe it's depression, maybe it's anxiety, it starts to pop over a line where it starts to interrupt their life. Have trouble showing up at work, have problems with relationships. That's when a mental health condition or a substance use condition starts to become what they call clinically significant, right? And you can start to have a diagnosis. So when you pop over that line, you go to the next line, you've been hospitalized, you've got a psychiatric event, you've had a suicidal ideation, you've gone to the hospital, and you stayed at the psychiatric hospital for 2 weeks, you've crossed another line. And the chances that you can just ignore it and go back to life as it was, pretty slim. And you might need some level of all of this. There are some people that have, older, and they have families, and there's other kinds of things. Maybe they go home, but at home, we dial in a lot of support around them at home. So we make their PHP environment at home. They've got good support, they've got people to talk to, they've got great therapists, they've got a good doc, etc. So, if you don't follow your plan, the chances of the cycle starting over really high.